Good afternoon, everyone. As you're entering, please put yourself on mute. We will begin promptly at 1 p.m. Thank you. Okay, we are at 1 p.m. Hello, and welcome to the APIC Great Lakes 2023 Educational Webinar Series. This month, we are excited to host Dr. Tiffany Wiksten, DNP RN CIC, the Associate Director, Standard Interpretation Group of the Joint Commission on Demystifying the Joint Commission, Infection Prevention and Control Challenges and Strategies for Success. To ensure we can all benefit from this webinar, please keep your line on mute and not hold. Hold may play a message or music disrupting the webinar. If you have a question, please drop it in the chat so that we can ensure your question is brought forward during our question and answer portion of the webinar. This webinar does meet the requirements for the Certification Board of Infection Control and Epidemiology for one infection prevention unit under Management and Communication. Please complete the survey on the last slide to earn your IPU. The survey link will be reviewed weekly, with IPU certificates being emailed to participants once a week. This webinar does not provide nursing continuing education credits or CEUs. But on behalf of the APIC Great Lakes Education Committee, we hope you will find this information beneficial to you. Tiffany Wiksten, DNP RN CIC, is currently an Associate Director in the Standards Interpretation Group in the Division of Healthcare Improvement at the Joint Commission, and is one of the infection control subject matter experts. In this role, she is responsible for working closely with accredited and certified organizations to interpret Joint Commission standards, identify vulnerabilities, and improve their performance. She also responds to inquiries from accredited organizations and the public related to compliance with Joint Commission standards. Dr. Wiksten reviews and determines the status of post-survey reports, clarifications, measures of success, and evidence of standards compliance submitted as part of the survey process. She provides leadership and guidance within the team in all aspects of the accreditation process through the clinical expertise in infection prevention and control. She also supports customer relationships management and the field representative cadre, as well as other customers through the provision of expert interpretation, guidance, and collaboration. Prior to joining the Joint Commission, Dr. Wiksten worked as an infection preventionist for 9 years. Most recently, she was the manager of infection prevention at a major metropolitan medical center. She has led infection prevention programs and efforts in a variety of healthcare settings, including large academic medical centers, community hospitals, and ambulatory settings. Dr. Wiksten received a Bachelor of Science in Nursing from Lewis University, Romeoville, Illinois, a Master of Science in Nursing from La Loyola University, Chicago, Illinois, with a focus in population-based infection control and environmental safety, and a Doctorate of Nursing Practice from Rush University, Chicago, Illinois, with a focus in transformational leadership. She holds a green belt in Lean Six Sigma and is certified in infection control. And now I'm going to turn it over to Tiffany. Thank you.
Thank you so much. I am so excited to be here today as an infection preventionist speaking to my wonderful infection prevention and control colleagues. Let's see here. I think I need to take over sharing my screen. Denise, you might have to stop. Perfect. All right. Give me one moment to get my screen shared and we'll be all set. Perfect. All right. So one of my main goals working here at the Joint Commission is to help demystify the Joint Commission infection control standards. I know when I worked in infection control in the healthcare organization, sometimes it was kind of a question mark as to what exactly the expectations were. So during this presentation, we're going to talk about some of those infection prevention and control challenges and some strategies that you can put into place to help ensure that you have a successful infection prevention and control program. All right, this is just our little disclaimer. All of these slides are current as of today, November 28th. What I really want to point out is that the information that's on the slides is not going to be nearly as much as what we talk about during this presentation. So interpretation of the slides alone does not represent the full context of what we're going to talk about today. So our objectives, right? Pretty short and sweet. We're going to discuss the top 2022 infection control non-compliance standards. And I know you're going to say, Tiffany, we are at the end of 2023, but I assure you they are actually the same top standards that get scored year to year. So we're going to revisit these again probably next year. I'm going to provide you with some examples for how to identify the root cause of non-compliance with the infection control standards, because it's not always the person didn't do the thing. Sometimes we don't have the right resources in place to make sure that they can do their job. We're going to help clarify the expectations of the infection control standards and also review strategies for how your organization can support infection prevention and control initiatives and activities. All right. So here's our top 5 infection control findings from 2022. And number 1 is IC221EP2, which is related to sterilization and high-level disinfection, right? IC221EP4 related to storage. IC211EP1 related to implementation of your infection control plan and your infection control activities. IC221EP1, which is related to low and intermediate level disinfection, and IC211EP2 standard precautions. So what I first want you to think about is that these are all implementation standards. They start with IC02. The reason why these are oftentimes the most frequently scored infection control findings is because there are a lot of opportunities for us to observe people implementing infection prevention and control activities, right? You typically have one infection control plan, you do one infection control risk assessment, you write up one set of infection control goals. So if we find opportunities in those, right, they're going to be scored a lot less frequently. These are surveyors watching healthcare workers, healthcare staff, implementing your infection control activities. And what I really want to highlight here is number 1 for the most frequently scored, and believe it or not, we're going to talk about it being the highest risk findings too, is sterilization and high-level disinfection, which of course are very, very risky for our patients. When we look at the Joint Commission's SAFER matrix, right, the Joint Commission provides a SAFER placement scoring for the top 5 infection control findings. And what you'll see here is the yellow is lower risk, that orange and red are higher risk, and this little fella on the end right here, the maroon guy, is where immediate threat to health and safety lives. So you can see that IC221EP2 related to sterilization and high-level disinfection, the majority of the observations made, or the RFIs that are scored by surveyors, are high-risk observations. And it's where most of the immediate threat to health and safety live. Now, this is representative of all of the infection control findings from 2022. So every single thing, every standard and element of performance. You can see that 1.2% of all infection control findings were related to immediate threat to health and safety. Another 27.7% were in that high risk category. So almost 30% of all infection control observations are in that high risk to immediate threat category. The other 70% are low to moderate risk. So hopefully at this stage, you're all familiar with the approach to assessing compliance with infection prevention and control requirements. I lovingly refer to this as the infection control hierarchy. We'll do just a very brief overview since hopefully you're familiar with this. And if you're not, that's okay, right? There's a link on the bottom here so that you can go to it and you can have it at your fingertips to reference whenever you need. This infection control hierarchy is actually a framework that was developed by the Joint Commission in April 2019 to assist organizations with understanding how to prioritize your resources or your sources of information when you're evaluating and developing infection control activities and infection or activities that have infection control implications. So when we take a look at this framework, you have to start at the top and work your way down. The top three boxes are requirements. First is rules and regulations. So think FDA, OSHA, EPA. Your state might also have hospital administrative code or healthcare administrative code that you have to follow. Or they may require you to follow a specific evidence-based guideline. So here in Illinois, where I'm from, our hospital administrative code says we have to follow things like CDC disinfection and sterilization guidelines, CDC hand hygiene guidelines, CDC guidelines for environmental cleaning. Next are CMS requirements. If your organization is deemed, you have to be compliant with CMS requirements. So those state operations manuals that apply to the setting that you provide your services in. Next is manufacturer's instructions for use. We're going to talk about manufacturer's instructions for use pretty extensively in a few slides, just because everything that we use in healthcare, virtually, I should say, has instructions for use or labeling. So the FDA requires the manufacturers of medical supplies, instruments, devices, and equipment to develop one, labeling, right? So that could be single use, single patient use, or reusable. And they also, for reusable items, require that those manufacturers develop validated instructions for reprocessing. That means everything from cleaning through decontamination and preparation for high-level disinfection, sterilization, or even lower intermediate level disinfection. The manufacturer's instructions for use may also reference evidence-based guidelines that you should be following. So the next bucket here is evidence-based guidelines and national standards. Now, there's a few evidence-based guidelines that the Joint Commission requires. So first is CDC standard precautions. Next is CDC transmission-based precautions. And then organizations are required to choose either CDC or World Health Organization hand hygiene guidelines to incorporate into your hand hygiene program. So if the evidence-based guideline or national standard, and we'll put consensus documents in there too, aren't required by regulation, they're not incorporated into the manufacturer's instructions for use, or the Joint Commission doesn't require them, your organization can choose which evidence-based guidelines, national standards, and consensus documents to incorporate into your policies, processes, and procedures. One thing to note is that the use of evidence-based guidelines, national standards, and consensus documents, if they're less restrictive than regulation or instructions for use, you can't use evidence-based guidelines, national standards, or consensus documents to avoid following rules, regulations, CMS requirements, or manufacturer's instructions for use. The last bucket down here is the blue one. That's your organization's infection prevention and control processes, policies, and protocols. Why this is really important is because if you write a process, policy, or protocol that is more restrictive than rules and regulations, CMS requirements, or manufacturer's instructions for use, the surveyors will survey to your policy, process, or protocol. You can't write a policy, process, or protocol that is less restrictive than rules, regulations, CMS requirements, or manufacturer's instructions for use. And while risk assessments are a wonderful tool, you can't perform a risk assessment to avoid following rules and regulations, CMS requirements, or manufacturer's instructions for use. All right, so we talk about the Swiss cheese model all the time, right? I've referenced it probably the entire 20 years I've been in healthcare. A safety event occurs or a near miss occurs, and you're like, well, it made it through all the layers of the Swiss cheese, right? And Dr. James Reason, the Swiss cheese model is genius, right? Because you really start to think about all of the layers of a process and the inherent vulnerabilities within each layer, right? So some processes only have 4 slices of cheese, and maybe they have little itty bitty holes that don't align, right? So you have a process that doesn't have too many steps. There aren't too many vulnerabilities in the process. So the likelihood that an error will make it through those 4 layers of cheese is probably pretty small. But then you have processes like sterilization or high level disinfection that might have 20 layers of cheese. And some of those layers of cheese have holes almost as big as the slice of cheese, right? Because we have products that we need to use, we have processes that we need to follow, we have humans who are performing the steps of reprocessing. So there's opportunities where the holes, where the safety events can make it through the holes of the cheese. So the holes of the cheese are either levels of the process, they could be mitigation steps, right? So something that, like the last layer of cheese for sterilization, could be the person at the point of use who's going to take a look at this instrument or device or a sterilized pack and determine should I use it or not, right? Your last layer of risk mitigation. As we navigate through these slides, I want you to think about what is the root cause, right? We're going to talk a bit about common observations that surveyors make. And I want you to think about, was it resource availability? Maybe think about it in the context of your organization. Are we providing the resources that people need to do their jobs? That could be supplies, that could be policies, processes, or procedures, or things like manufacturer's instructions for use. The process that was developed, is it compliant, right? So we've seen a couple of times where an organization has written a policy or a procedure that is less restrictive than the manufacturer's instructions for use. If you develop a process that's not compliant and teach it to your staff, they're going to do it, but that doesn't mean that the process is good. Then we think about education, training, and competency. Do the staff have the education, training, and competency that they need to be able to perform their job functions? We'll talk about that more towards the end of this presentation. Individual accountability. Are individuals accountable to perform their job functions as intended? And if it's a critical process or a risky process, or maybe a process where you've identified that there have been some opportunities previously, is there someone who's providing oversight, maybe some auditing or some follow-up to make sure your processes are being implemented as intended? So understanding the root cause of the observation or the noncompliance can help guide your activities and resource allocation. So sometimes it's a short-term fix, right? You need a thing, all you have to do is buy the thing, and your problem is fixed. But for a lot of opportunities in healthcare, right, it's probably not that easy. It could fall anywhere on this continuum. We did a great, it was a 4-year long project at one of the organizations that I worked at. We were tackling C. diff. And there were probably steps along the way where you had to put a fix into place, right? But you knew that there was going to be a longer term project because you wanted a long term solution, a sustainable solution. So understanding the root cause of what is leading to the noncompliance or the observation or the increased, SSI rate or CLABSI rate can help guide your activities and your resource allocation. So this is the Joint Commission spaghetti. That's what I like to call it. A lot of times I hear, the Joint Commission doesn't look at our infection prevention and control processes during the survey, right? We're very familiar with the infection control tracer session, where we sit down in a room and it's partnered with medication management and it's partnered with data. And we look at the infection control plan and talk about some highlights of your infection control program. But tracers for your infection control activities are woven throughout the survey process. So they might start in the ICU and they might take a look at a patient who's on a ventilator and has a urinary catheter and a central line. And they may want your policies to take a look to see, are you following your policies for central line care and maintenance? Or maybe if the patient goes off to interventional radiology or CT, is their urinary catheter being managed as per your organization's policy, process, or protocol? Right? They might look in your emergency department to see if patients who are coming in are being screened for infectious diseases as per your organization's policy, process, or protocol, right? So while they're making their way through your organization, they're also looking at those infection prevention and control activities and how they're implemented. Hand hygiene, wearing PPE for standard precautions and transmission-based precautions. So, what you might find is as the surveyors are navigating through your organization, they're identifying risks, right? That's what we're here for. We're your extra set of eyes. Sometimes, when we round in our organizations 150,000 times, we start to maybe not see some things, right? We're so used to seeing that cart parked there. Maybe we didn't look inside those drawers. Surveyors they're like laser focused. They see a cart sitting there, they're going to open those drawers and they're going to be like, what is this thing? Why is it expired? But when they identify a risk, sometimes they ask for additional information. They might ask for the manufacturer's instructions for use. If it's in high level disinfection or sterilization, if there's a critical step missing in the process, they might ask to review education, training, or competency for the person who's performing high level disinfection and sterilization. So as they ask for additional information, there may be additional opportunities identified that could be scored outside of the infection control chapter. So first would be resources. Now we do have a standard that is related to resources for infection control for information, equipment, and supplies. But if it's a pervasive issue, that could actually be scored under leadership. They could score under leadership for activity management or oversight, right? Say we find an observation about, the ultrasound probes and radiology weren't being disinfected as required by the manufacturer's instructions for use. Well, if the manager of radiology has oversight of their process, leadership of radiology could be scored for not managing the implementation of that process. Or oversight, infection control oversight. We know that infection control is not responsible for all areas of the hospital, but if it's an area that has infection control implications, right? Have you dedicated resources to round in those areas? And is rounding or auditing being performed? Right? If it's being performed and you're finding noncompliance, who's that being escalated up to? And then last, human resources. So education, training, and competency. Again, we'll talk about this a little bit more towards the end, but do staff have the education, training, and competency that they need to be able to perform their job functions? So we're going to take a look at some of the most frequently cited infection control observations, and we're going to find out what's at the root. So first, we're going to start with implementation. These are some key elements that surveyors are looking for the implementation of infection control activities. Again, first, that the process that was developed is compliant. Staff have the resources they need to perform their job functions. And these are very human driven, right? Competent employees who are accountable to perform their job functions as intended, infection prevention and control involvement, and oversight of critical processes. We're going to talk a bit about IC 020201 EP2 sterilization and high-level disinfection because it is the #1 most frequently cited higher risk accreditation requirement for hospital program, the ambulatory program, and in the top 10 infection control findings for programs that have sterilization and high-level disinfection. It is also where the highest percentage of high risk findings and findings evaluated for immediate threat to health and safety live. So these are some of the key elements that our surveyors are looking for when they're reviewing sterilization processes. First, of course, is available supplies. And you're going to start to see this pattern here, right? The manufacturer's instructions for use are available. The supplies necessary for all steps of reprocessing are available. Manufacturer's instructions for use are followed for all steps of the process. So that is handling used items at the point of use, cleaning, sterilization, documentation, storage, transport. If there are conflicts identified within the manufacturer's instructions for use or between the manufacturer's instructions for use between, like, say, an instrument or device or a sterilization accessory, that those conflicts are resolved. They're going to look for competent employees to see that staff who perform sterilization are trained and competent, and the staff who have oversight of that process know what they're looking for. They're going to evaluate to see if infection prevention and control has a process to evaluate adherence to procedures and if staff are held accountable to perform their job functions as intended. So when you think about your organization, there are a wide variety of instruments and devices used in healthcare settings across the continuum. A lot of them are found in central locations, right? So your OR, interventional radiology, probably your labor and delivery OR. But there are a lot of instruments and devices that are found in decentralized locations. So think about your intensive care units, your emergency departments, and ambulatory locations. So there might be bedside procedures or minor procedures being performed, specialty services that you have a significant amount of reusable items that require sterilization. So any dental clinics or dental locations, podiatry, gynecology, endoscopy, or urology. When you look at the instruments and devices that you have in your organization, take a look and see, are they single use or reusable? There's varying levels of disinfection or sterilization required. What we're finding recently that seems to be difficult for some organizations to manage are these single use instruments or devices that come with instructions to sterilize them. So the manufacturer is supplying them non-sterile, and they are required to be sterilized prior to their one and only use. So it can be a bit confusing because we think single use shouldn't have instructions for reprocessing, right? A lot of our instruments and devices have varying levels of complexity. Think about simple stainless steel surgical instruments versus these crazy big sets of orthopedic instruments, right? If you've ever seen a hip replacement and you see that thing that looks like a cheese grater on the end of a stick, right? Those things are really, really hard to clean. And there's a wide variation in reprocessing instructions. So think about in your dental settings, if you have them, that's like the number one place where if you have a dental setting and they have dental handpieces, which they probably do, there could be 10 different dental handpieces and they could have 7 different instructions for sterilization. So, what level of reprocessing is required for instruments or devices? So, FDA follows Spalding classification. CMS also follows Spalding classification. So, the intended use drives the minimum reprocessing. So, for critical procedures, so items that come into contact or enter sterile tissues, sterile body cavities, or the vascular system, they require sterilization. For semi-critical items that come into contact with mucous membranes or non-intact skin, they require at minimum high-level disinfection. Although some things in the dental world or in gynecology might only provide instructions for sterilization, right? So as long as it supersedes the minimum requirement, that's okay. And non-critical items that are intended to come into contact with only intact skin require cleaning and low or intermediate level disinfection. So again, what is a single-use device? And I like this little slide here because the part that's underlined isn't necessarily true as we're finding it anymore, right? The labeling may or may not identify the device as single-use or disposable and does not include instructions for reprocessing, but some of them do include instructions for processing them prior to use. So if you're unsure if an item is single use or reusable, contact the manufacturer for clarification and obtain their response in writing. It's really, really, really important. So the manufacturer's instructions for use. When we talk about sterilization or even high-level disinfection, most items utilized throughout the steps of reprocessing will have instructions for use. So this includes the instruments, devices, or equipment themselves. This includes equipment like sterilizers, washer decontaminators, ultrasonic machines, cleaning accessories or accessories used for reprocessing. So pouches, sterilization wraps, sterilization containers all have instructions for use. Your process indicators, so your chemical indicators or your biologic indicators. I encourage you take a look at your biologic indicators and make sure that they are compatible with the sterilization cycle that you're validating. Several of these biologic indicators have a whole page of compatible cycles. And I can tell you those surveyors can sniff out the one time where you have a biologic indicator that's being used for a cycle that it's not approved for. The manufacturer's instructions for use provide instructions for use, maintenance, cleaning, disinfection, or sterilization, and when the item is no longer suitable for use, right? And they also will tell you compatible disinfection and sterilization products and processes. So again, they may have instructions for reprocessing that surpass the intended use. Your manufacturer's instructions for use may also be ambiguous or contain conflicting information. So if you don't know what they're telling you to do, if you're unclear, Or say your manufacturer's instructions for use, it's a vaginal probe, right? We know it's coming into contact with mucous membranes. They don't have instructions for high-level disinfection or sterilization. You need to contact the manufacturer for clarification. So if there's a conflict within a manufacturer's instructions for use or between manufacturer's instructions for use for items, so between an instrument being sterilized and its sterilization accessory being used, so a pouch, a wrap, or a container, or if the manufacturer's instructions for use contains unclear or ambiguous information, contact the manufacturer for clarification and obtain their response in writing. So this is really, really, really critical. Know your instruments, devices, and equipment. Typically in large central sterile locations, this isn't too big of an issue. You have a very qualified, educated staff. This is their dedicated job. They know the types of sterilizers that are in use, the sterilization cycles that are used. But sometimes in our decentralized locations that may have tabletop sterilizers where sterilization is only a fraction of the staff's responsibility, they don't always know the sterilization cycle that that sterilizer provides. And you need to know the sterilization cycle that is provided by that sterilizer so you know which set of instructions for use to follow in the instrument or device instructions for use. So gravity displacement sterilizer, time and temperature could be vastly different than the time and temperature requirement for dynamic air removal. So you have to make sure that you follow the manufacturer's instructions for use on the instruments or devices being sterilized based on the type of sterilizer in use. And I want you to keep in mind that one standard sterilization cycle and parameter may not be sufficient for reprocessing the different types of instruments and devices being sterilized, right? So if you have a small wound care clinic that has simple stainless steel surgical instruments all from one manufacturer, one sterilization cycle time and temperature might be okay. But if you're in a dental setting or in another setting that uses a wide variety of instruments, you might need to have several different sterilization cycles and parameters in use. So just some common observations. I'm not going to spend too much time going over these, so we have some time at the end for questions. But what I want to point out on this slide is in red, right? This is where immediate threat to health and safety gets evaluated and sometimes determined, right? So if the sterilization cycle parameters are not met per the manufacturer's instructions for use of the instrument or device. So sterilizers will sometimes provide sterilization cycle time and temperatures, like general sterilization cycle time and temperatures. Sometimes your sterilization accessories will provide general sterilization cycle time and temperatures. You can't use those in place of the instrument or device manufacturer's instructions for use. So if there's a difference between the instrument or device and the sterilizer or sterilization accessory in use, and you want to find out which one is the correct one, you need to contact the manufacturer of the instrument or device and the sterilizer or accessory and get their response in writing, right? So the manufacturer of the instruments or devices are required by the FDA to validate the sterilization cycle parameters included in their instructions for use will yield an instrument or device that is sterile. So that is your baseline, right? You need to meet the manufacturer's instructions for use for the instrument or device being sterilized. So instruments and devices not appropriate for sterilization, right? There should be an inspection period in sterile processing where the people who are in pack and prep or even in decontamination are looking to see if these instruments need to be removed from service, right? So single-use devices. I'm convinced nobody intends to reprocess single-use devices because it's not allowable by the FDA unless you're a third-party reprocessor, but sometimes they accidentally find their way in there. Instruments in disrepair, so they're oxidized, chipped, cracked, right? That means that there's a possibility, one, that they aren't able to be appropriately sterilized, but two, they could be a safety issue for patients. Instrument tape or coating that's not properly applied or it's chipped or cracked. Totally fine to have instrument tape as long as it's approved for use with the sterilization method in use and it's applied correctly and it's removed when the manufacturer says it has to be removed. So if one manufacturer says it can only be wrapped around an instrument 1.5 times and it needs to be removed when it starts to fade, peel, or chip or crack. We count for surgical instruments, but we don't count for chips of tape that come off during surgical procedures. Sterilization of non-medical items. I encourage you, go look in your D&C trays and make sure that there are not soup spoons and Sunday spoons in your D&C trays. We've seen them in TERP trays, D&C trays, unfortunately a handful of orthopedic trays. But there are medical grade spoons that organizations can procure for the purpose that these spoons are being used. Usually they're just used to transfer material from point A to point B that have been removed from the patient's body. However, there's no instructions for sterilization, and a lot of times they are being sterilized in packs with other instruments. And last, remember, this is our last layer of the Swiss cheese. Staff can't identify instruments that should not be used, especially at the point of care, right? They're our last line of defense in the OR, in IR, in labor and delivery OR, where staff spend a lot more time, right, looking at sterile instruments. They can probably identify oxidized things that can't be used or shouldn't be used, or things that are in disrepair, tape falling off. But we find in some of our decentralized locations, like the ICU or the ED, sometimes in ambulatory areas, staff don't identify that an oxidized instrument or a chipped instrument should not be used. So again, manufacturer's instructions for use conflicts and clarification. Sometimes we see it scored when the IFUs are not clarified, or the IFU between an instrument and a sterilization accessory not clarified if there's a difference in sterilization cycle time and temperature. Immediate use steam sterilization plays a very important role. I sometimes hear that, the Joint Commission says you cannot perform IUSS. That is not true, but IUSS it has a very important reason, right? If you have a unique instrument and it becomes contaminated, and you have staff who have the instructions for use and they can perform decontamination and sterilize that item per the manufacturer's instructions for use, right? Because you have a patient on the table under anesthesia, that would be an example of appropriate use of immediate use steam sterilization. Sometimes what we find though is that we have a provider who comes in who does 12 cases every third Thursday, and we only have two instrument trays or instrument sets, right? And they're turning those around for the next case. Oftentimes the manufacturers of full instrument sets will say a full instrument set should not be undergo IUSS, right? Because the process itself is inherently more risky. You have staff whose job is not dedicated to only performing cleaning, decontamination, inspection, and sterilization of the instruments. They're often doing several other things, but manufacturers' instructions for use often don't allow for immediate use steam sterilization of full sets. Another reason why we see immediate use steam sterilization that is really not an appropriate reason is if your vendors are not dropping their trays off in time, right? So you should have a contract with your vendors that says the trays are to be dropped off at X amount of time frames so they can go through terminal sterilization. All right, so some key elements of high-level disinfection. We should be starting to see these as familiar, right? Available supplies, manufacturer's instructions for use followed for all steps of the process from point of use through storage, competent employees, infection prevention and control involvement, and staff accountability. So when you think about manufacturer's instructions for use being followed, think about the most complex thing that I can think of, which is an endoscope, right? There are a whole significant number of brushes and flushes. And if you flush before you brush and you don't flush after you brush, you could be leaving debris in the channels. So making sure that all of the steps of the process are being performed correctly in the right sequence is really, really important. So some observations related to high-level disinfection. So one that we see kind of frequently now is this enzymatic solution. So there are some enzymatic solutions out there for cleaning or pre-cleaning that require specific ratios, like 1 ounce to 1 gallon. And so surveyors will say, well, how do you know it's 1 ounce to 1 gallon? And we don't have any line in the sink, and we can't tell that it's diluted correctly. Or some of them have a temperature requirement. Don't use if the more than 130 degrees, or has to be used between 70 and 110 degrees. But these two items in the red here are really what I want to show you, right? Because this is, again, where immediate threat to health and safety is evaluated and sometimes gets called. So the manufacturer required minimum temperature of the high-level disinfection solution not met at the time of use. So manufacturers of several of the high-level disinfectant solutions say the solution has to be at least a specific temperature at the time of use. And we have queried them multiple times, right? Every couple months, we like to see if there's anything new that has changed. And they have not yet endorsed if it's used even a half a degree colder that it has high-level disinfected that item. So if the manufacturer says the minimum temperature is 68 degrees, the temperature of the solution has to be at minimum 68 degrees at the time of use. Or the item is not soaked in the high-level disinfectant for the minimum amount of time specified by the manufacturer's instructions for use, right? This is like the contact time. So if the IFU says 12 minutes and it's only soaked for 6 minutes, the manufacturer of the high-level disinfection solution will not guarantee that the item has been appropriately high-level disinfected. So this is just a quick reminder, right? Failure to follow the manufacturer's instructions for use at any point in the process can lead to issues such as altered functionality of the instrument, device, or equipment, which could be a safety event, right? Not everything is an infection control risk, but it could also result in the inability to high-level disinfect or sterilize the instrument, device, or equipment. That is the infection control issue, right? When we talk about ICO 20201 EP1, so low and intermediate level disinfection, there's two main concepts. One is product selection, and the other is contact time. You have to make sure that you're selecting a product that is approved for use by the manufacturer of the item that you're disinfecting. Glucometers are a really popular one. We have this story of the surveyor who picked up a glucometer, and the whole screen, right, the screen where you read the value was all foggy. And when they reviewed the results, they realized that there was a critical result that had been missed. It said 22, and the staff thought it was 82 because the screen was so foggy, they couldn't actually see the number beneath it. So the correct product choice is important because manufacturers they can't say, right, they haven't tested any other products, that the other products won't degrade their equipment. And then contact time. We have come light years, right? I remember back 15 years ago, you'd ask a staff member, what's the contact time? They would have no idea what you were talking about. But now they know, right? They can point to 2 minutes or 3 minutes or 5 minutes or however long the contact time is, but we still have this little gap because they don't understand that it means the wet time, right? So they say, I'm going to wipe this thing and I'm going to come back in 3 minutes. And when it's dry, if it's dry in 3 minutes, right? They don't understand the contact time is the wet time. We're going to talk for a minute here about blood glucose monitoring supplies. And the big issue that we're seeing is in areas like home health and behavioral health care. I will say I don't think we're seeing this particular issue in large healthcare organizations because you typically have, a contract for, healthcare grade glucometers. However, in some of these areas where we're providing services for patients who are either non-compliant or have medical need, right? They don't have the resources to buy a new glucometer. We find that we have these very well-intentioned staff who go out and buy a blood glucose monitor from the drugstore down the street, right? We've heard this a couple times. We have a behavioral health outpatient clinic, and we have patients who are coming in who are non-compliant. They're not testing their blood sugar. So somebody's like, I'm just going to go buy a glucose monitor at the drugstore. Now, there's a couple inherent issues there. One, they're not healthcare grade, right? So they're not guaranteed to work effectively for healthcare needs, I suppose. There's usually not instructions for disinfection using healthcare grade disinfectants because they're intended to be used by one person in a home setting. But they often come with a lancet holding device or a finger stick device, and they come with little lancets. And what happens is people don't realize that you can't use those for more than one person. So if during survey, a surveyor were to find a lancet holding device or a finger stick device in place, along with a glucometer, right? If we find that that lancet holding device or finger stick device has been used for more than one patient, that can also lead to the determination of immediate threat to health and safety. Also, if your equipment is not being disinfected after each use, right? We know that those CDC studies about transmission of bloodborne pathogens were mostly focused in like nursing home, long-term care settings. However, I want you to think that, especially during breakfast and lunch and dinner, staff who are performing blood glucose monitoring may be going from room to room to room. So while they're not all sitting at the same table, if that equipment is not disinfected after each use, you're putting the next patient at risk. This is just a little light reading for you in case you had any questions about that finger stick device. Standard precautions. We're not going to talk about all of them. These are the CDC standard precautions, right? We're going to talk about the ones that we see cited most frequently. And so here are our key elements. So resources, staff have access to supplies and protocols. Employees are trained to know when standard precautions are apply and are trained to use supplies or products. Standard precautions are implemented at clinically appropriate times and as intended, and procedures are enforced and actions are taken when issues are identified. Some of our observations are standard precautions are just not performed. So hand hygiene after glove removal, gloves not worn when obtaining blood for blood glucose monitoring, supplies not available. For personal protective equipment, OSHA requires organizations to have an exposure control plan, which is a written document that guides your personal protective equipment program. It should be risk assessed and updated annually. You need to make sure that PPE is available for the types of exposure, size to fit healthcare workers, and available in locations of use. Your employees should be trained to know why specific PPE should be used. They should be competent to choose the PPE that they need, and they need to be trained to don, doff, and discard single-use PPE or disinfect reusable PPE. And again, use needs to be enforced and action taken if issues are identified. These are just some of a couple of the observations that surveyors make regarding personal protective equipment, right? So if it's not worn, when they pull the thread, they find out that maybe the OSHA hazard assessment wasn't performed, or the process or procedure was unclear, or the supplies were just not available. Maybe the staff didn't correctly don or doff the PPE. So they didn't put the N95 mask on with the two straps that go over the head and, pinch it down around their nose. Or if you've ever seen that employee that's, pretending they're the Incredible Hulk and they're just ripping that yellow isolation gown off, like there's no tomorrow, right? And contaminating themselves or the environment. Or those beautiful reusable respirators that we got during COVID, right? Those need to be cleaned and disinfected. When we talk about CDC standard precautions, medication and injection safety, these are just some of the key things surveyors are looking for, that your activities align with laws, codes, regulations, and manufacturer's instructions for use. So single dose vials or multi-dose. Supplies are available, of course, right? Needles, syringes, things like that. Your observed activities align with your organization's policies, processes, and procedures. And the interventions and activities are implemented in all relevant components and functions. Okay, and that means, we'll talk about that in a second. In the red box here are all of the CDC injection medication safety guidelines, but in the blue box here are the top 3 things that we see scored most frequently. So for injection safety, failure to swab the top of vials before access. And so implemented for all components and functions means for everybody who accesses these vials. If it's an MA, if it's a nurse, if it's a PA, if it's a provider, if it's anesthesia, wherever vials are accessed, right? Every staff member has to be accountable for swabbing that vial. Sometimes we see multi-dose vials taken into a patient treatment area. If it's a multi-dose vial, it needs to be accessed in an area that is not a patient treatment area. And while we can't believe it, that it's even on this slide, we are still seeing bags of IV fluids used to make patient flushes, right? Keep an eye out for those. We know that those have been implicated in transmission or clusters of infection too. For storage, we're looking to see that there are no expired supplies available. Items are stored in a manner to protect them from contamination, so no visible soil, clear separation of clean and dirty, and staff are accessing supplies with clean hands. And that items are stored in a manner to maintain the integrity of their packaging and per manufacturer's instructions for use. So some of the things that we see, of course, we see a lot of expired supplies, hairs or dirt in drawers where medical supplies are stored, holes or tears in packaging. And this is a big one, right? Staff accessing clean supply cabinets like nurse servers with soiled hands or going into a clean supply cart with gloved hands worn during patient care. I think we see this like in the ED, right? When they're in a hurry and they're trying to take care of a patient, and you see them reaching into that cart of supplies that are there for their convenience with those dirty gloved hands. All right. Again, when we talk about implementing infection control activities, you have to make sure that the activities that you developed are compliant and that your activities are implemented as intended in all relevant locations for all relevant staff. So this means if you have a hand hygiene policy that applies to all staff who provide direct patient care, and you decided that you needed to have an educational component, say you developed a 5-minute video for everybody to watch, that would mean that everybody who provides direct patient care should watch that 5-minute video. Right? This is not Tiffany telling you you have to develop a 5-minute video for hand hygiene. But if that was something you required for all staff who have direct patient care, you would want to make sure that that is implemented for all of those staff, as opposed to processes that are developed for pre-cleaning endoscopes, right? Pre-cleaning endoscopes at the point of use would only apply to staff who are at the point of use and need to pre-clean endoscopes. Again, this is just our loving infection control hierarchy. Make sure that when you're evaluating or you're creating activities, infection control activities, or activities with infection control implications, that you're following the hierarchy. Some of the things that we see when we score IC 020101 EP1, which is the kind of the bucket for infection prevention and control activities, is not following regulations and requirements. So this could be food code. This could be state code for laundering hospital linens, right? It either has to meet a certain temperature or you have to use specific chemicals. Not following the manufacturer's instructions for use for things that are not related to high level disinfection or sterilization, right? So maybe failure to use skin prep products and antiseptics in a manner consistent with the manufacturer's instructions for use. So you're supposed to apply it and let it dry for 3 minutes, and you see staff blotting at it with a paper towel or waving their hand over it to make it dry faster. Sometimes it's not following the organization's process, procedure, or policy. So staff not following the organization's OR attire policy. And again, not implemented for all relevant components or functions or lack of staff accountability. We've got a couple scenarios, right? So could this get scored during survey? I want you to think about that infection control hierarchy. So one, does the Joint Commission prohibit healthcare workers from wearing gel nail polish? Well, the answer is no. The Joint Commission does not specifically prohibit healthcare workers from wearing gel nail polish, but we will survey to your organization's policy, process, or procedure that should be developed based on regulation and any required or chosen evidence-based guideline related to hand hygiene that might address gel nail polish. Scenario two, if during survey, my organization has a policy that states that I must reprocess unused scopes or probes every 7 days, even if the manufacturer does not require reprocessing of unused scopes or probes, and the surveyor observes a scope or probe in storage that was last reprocessed 9 days ago, could we be cited for noncompliance? And the answer is yes. If you develop a policy, process, or procedure that is more restrictive than regulation or manufacturer's instructions for use, you could be scored for not following your organization's policy, process, or procedure. And last, if our organization's policy states that we allow fabric head coverings in the operating room, will we be cited for noncompliance? And how about covered arms? Again, we're going to look through the hierarchy. Is there any regulation that allows or prohibits fabric head coverings? In the state of Illinois, you can wear fabric head coverings as long as they're laundered by the healthcare organization, right? They have to be healthcare organization laundered, which is where the sticking point sometimes comes in, right? Because everybody wants their school cap bath. So it might be prohibitive. So we got a couple questions, right? And thankfully we had some FAQs that go along with these. Are fans allowed in patient care areas, labs, or other support areas in an organization? Well, it's up to your organization to decide where you're going to allow fans. you might have to evaluate the risk to patients in the areas. There's considerations for keeping the fans clean and sanitary. But one thing that the surveyor might take a look at is if they see fans in patient care areas, especially your physical environment surveyors, they might start to ask questions about your HVAC system. Like, why is this area so hot? Or why is this area so humid? Why do you need fans in this area? Right? And cardboard boxes, right? What is the Joint Commission's position on managing cardboard or corrugated boxes and shipping containers? Again, we typically follow this through the infection control hierarchy. Is there any regulation that addresses cardboard boxes? So, in pharmacies or areas where sterile medications are being prepared, sometimes food code will address cardboard or corrugated boxes. If there's no regulation, right, your organization needs to take a look at the cardboard or corrugated boxes and try to figure out what is the purpose, what kind of risk or potential for risk for contamination, right? I like to tell the story that when I worked in a pharmacy before I became a nurse, we had a whole shipment that came in. I was working back in the pharmacy, and all of a sudden there's little lizards in the pharmacy. They actually had invaded these boxes of pharmacy supplies that were shipped from Texas, and we had lizards all over our pharmacy. So not only like spiders and other little creepy crawlies, right, but they can harbor other bugs and insects. And we all know that they love to suck up water. So if there's no regulation that says you can't have corrugated boxes or cardboard, your organization really needs to evaluate where you're going to allow cardboard. External shipping containers are usually really dirty, right? You have to think, do you want to commingle those? Well, I shouldn't say, do you want to? You really shouldn't commingle them with clean supplies, right? Because you could potentially contaminate those clean supplies. But this here is a FAQ, an FAQ for you to refer on how to kind of go through that decision-making process. All right, supporting your infection prevention and control program. So just appreciate, and I'm sure you all do, right? There are many specialized services provided in healthcare that have infection control implications. So first and foremost, infection control, intensive care. Think about emergency, oncology, bone marrow, burn unit, where we're providing protection for those patients. Child life, where patients have developmental needs as well. Specialty services, and of course, sterile processing and high-level disinfection. So we get asked the question a lot, what does the person responsible for the management of infection prevention and control activities need to know? Well, all settings have basic infection prevention and control needs, right? Regulatory compliance, risk assessment, standard precautions, transmission-based precautions, cleaning and disinfection. And some provide additional care, treatment, or services, so sterilization and high-level disinfection. Specialty services like dialysis or pain management, right? Those pain management clinics with their little needle things, or radiation oncology, or specialty populations like bone marrow transplant or maybe cystic fibrosis patients. For education, training, and competency, just remember that the education, training, or competency needs to be sufficient for staff to be able to perform their job duties. So education typically increases knowledge. Training typically focuses on gaining technical skills. And competency means somebody is competent to perform their job functions. So the organization defines what requires a competency, but it requires a qualified person to assess, and it requires a validation process. When you think about education, training, and competency, I want you to think about the context of staff who reprocess devices and instruments. And a one-size-fits-all approach may not apply, right? You may have staff in an ambulatory clinic who are only reprocessing simple stainless steel surgical instruments, all manufactured by one person, by one company. Or it could be the people who are working in sterile processing who are responsible for performing high-level disinfection and sterilization of full sets of really intricate trays. Process oversight. Organizations determine if processes should be monitored. If you decide that the process should be monitored, you need to assign a person to oversight, right? And make sure that they know what they're looking for. If they don't know what they're looking for at face value, they might think the process is being implemented really well, but then later they find out maybe they weren't measuring the enzymatic correctly. Maybe they weren't using the right brushes to clean the lumens of the endoscope, right? and are staff being held accountable? So if there's non-compliance identified, is the person who with oversight holding staff accountable to perform their job functions as intended? All right, we're coming to the end here. So critical elements of implementation, of course, resource availability, education, training, and competency, staff accountability, oversight of critical activities, and making sure that your activities are implemented in all relevant locations for all relevant staff. And make sure that you're fostering the safety culture, right? You want staff and people to come to you to be able to report things that maybe aren't working well or potential safety issues so that you can work to address them before they become a safety event. So in summary here, follow the hierarchical approach to ensure compliance with your infection control standards, provide the necessary resources for people to be able to perform their job functions, and ensure a culture of safety in which staff are held accountable to perform their job functions correctly to ensure staff and patient safety. These are just a million ways that you can connect with us. I'm always happy to answer questions if you have infection control questions and it's kind of gray, you want to submit a question or even have a phone call. I'm always happy to jump on a call and help you try to navigate. And so that's it. We're at the end. So thank you for helping us keep patients safe. I know I didn't leave a lot of time for questions. I'm so sorry.
That's all right, Tiffany. Thank you so much. This was such a fantastic sort of brain dump of all the great work that you and your team at the Joint Commission do. And I'm really grateful you were able to be here with us today. There were a number of really great questions in the chat box. So if you are comfortable with it, I will send them to you via email. We'll get some written responses and then we can get those out to the group just so that everybody has a chance to see them. Slides for today's session as well as the recording will all be made available. And I will put the link to both of those things in the chat. Our website is already in there. But again, just want to make sure that everybody has that information. I see Denise has pulled up our post-event survey. If you can scan that with your phone and complete the evaluation, we will get the IPU certificates issued to you. As Denise mentioned, we will be batching those out weekly. So again, I know we are right at 2 o'clock, but again, thank you, Tiffany, so much for coming and sharing your expertise with us. And like I said, we'll follow up via email to get the rest of these questions answered.
Excellent. Yep. I look forward to it. Thanks so much, guys.